So I was given the very small topic of measuring results of adolescent idiopathic scoliosis surgery and trying to do this in an evidence-based review format. There are 21 randomized controlled trials, 8 cohort studies. None of these include long-term health-related quality of life questionnaires, both pre and post-op. So I'm going to leave the first question to the last and try and answer the ones that are a little easier to answer, the short-term results, like what instrumentation should we use? Should we use bone graft, and what type of bone graft supplement? Should we, what can we do about blood loss and pain control? So when we look at instrumentation, there are 3 randomized controlled trials and 1 prospective cohort trial. I'd like you to focus on the LUCK trial, which looked at 4 different instrumentation techniques and showed they originally found that CD Horizon and Moss Miami seemed to give better correction, but when they went back and corrected for the flexibility on fulcrum bending, on a fulcrum bending correction film, they found that there was no significant difference at all between any of the instrumentation techniques or instrumentations on the percentage of correction that they got. So I would summarize that instrumentation, the type of instrumentation you use doesn't seem to make a difference. You should use the instrumentation you're comfortable with, that is safest in your hands, that will give you a reasonable outcome. It's unlikely that changing instrumentation is going to change your result. Let's look at bone graft. We have 3 randomized controlled trials. The first by Betts showed at 2 years there was no difference in pseudarthrosis rate between patients in which no graft was used, the local graft was actually thrown out, versus allograft. And then there's 2 fairly large randomized trials looking at calcium supplements, calcium phosphate supplements, and comparing them to iliac crest graft. And both of those showed no significant difference in pseudoarthrosis, and they seemed to find more pain and wound problems in patients who had iliac crest graft taken. When we look at blood loss, there were 8 randomized controlled trials looking at various techniques to limit blood loss during surgery. To decrease blood loss during surgery, it's clear that you can decrease blood loss by using hypotensive anesthesia, cell saver, preoperative hemodilution, and fibrin glue. And you can decrease your transfusion needs by using hypotensive anesthesia and cell saver. Now for the tougher question, should we operate? Well, we need a little background. In 1968, in the same issue of Acta Orthopaedica, there were 2 articles about long-term history of scoliosis. These patients were initially seen in 1910 through 1915, and they found mortality double expected, disability 8 times expected, and a preponderance of patients with chronic constant back pain. And so immediately we thought we need to prevent progression, deterioration, pulmonary compromise, and death by doing something. And that something started out with in situ fusion in a plaster bed for 6 months post-op. And this was a little tough on patients, and a lot of improvements in instrumentation have occurred over the years. Originally Harrington rods, which allowed us to get patients up in a brace and mobilized soon after surgery. And then it's evolved into segmental pedicle instrumentation. And now, in most cases, I will let my patients go back to soccer 3 months after surgery, and they never wear a brace. But in 2003, Weinstein published sort of a landmark article looking at the natural history more recently of patients with untreated idiopathic scoliosis. Those patients were seen initially in 1950 and followed out to 2000. There were 448 patients initially, and 117 were found in follow-up. And his conclusion was that late onset idiopathic scoliosis, what he calls LIS, or what we now call adolescent idiopathic scoliosis, if untreated, LIS causes little physical impairment other than back pain and cosmetic concerns. This was based a lot on the survival similar to controls, calculated on an expected mortality rate of the patients lost to follow-up. And I think this is a big step forward, but also I think he's seeing a little bit the trees instead of the forest. If we look at the curves in these patients, we see thoracic curve at skeletal maturity 60 degrees progressing on average at follow-up to 85 degrees. Thoracolumbar to 89 degrees. Lumbar curves didn't progress nearly as much, only to about 50 degrees, and double curves to 79 and 76 degrees. If we look at pulmonary function, in patients with curves over 50 degrees at skeletal maturity, the chances of having shortness of breath with activity at 15-year follow-up in 1968 was 15 times that of controls. And by 2003, at 50-year follow-up, if you had a thoracic apex with a curve over 80 degrees, remember the average was 85, the odds ratio for shortness of breath with activity was 10 times that of controls. He also looked at body satisfaction. He used a 0 to 6 scale and found that the patients with untreated scoliosis has much poorer scores than controls. And back pain prevalence was 77% in the untreated scoliosis patients versus 35% in the controls, which were a group of 65-year-olds identified at retirement homes. Whether that's an accurate assessment of the normal 65-year-old is of some question, I think. And if we tried to put this in context of the SRS and SF36 scores, I think the untreated patients would clearly be scoring lower than controls. Now, what about the results for adolescent idiopathic scoliosis surgery? Well, the best study we have is by Danielson, a 20-year follow-up of patients treated by Nachemsen's group. 156 patients were treated by Harrington rod between 1966 and 1977 that averaged 65 degrees pre-op and 35 degrees after surgery. These were compared to 100 age and sex-matched controls and 127 brace-treated patients. SF36 scores, psychological well-being scores, ODIs, and SRS outcomes were done on all these patients at follow-up, but they weren't available initially. And she found overall similar health-related quality of life to controls. Now, some may say we're not doing anything with that, but I would tell you that the natural history of that 65-degree curve was a lot different. They also found, in which we see this in many, many studies, that there seems to be no relationship between outcome scores and final curve magnitude. I looked at more short-term studies looking at health-related quality of life with scores both pre-op and post-op. There were 8 citations, 5 of which fit our criteria, and none of them had over 5-year follow-up. They all had 2-year follow-up. These are the 5 studies. The one at the bottom, Howard's study, is a class 2 study, prospective trial. He used a different scale, the Clement scale. If you look at the scores from pre-op to post-op, there's improvement in virtually all of these, which is fairly remarkable for a, quote, asymptomatic condition. So in the short term, we can say there's really no evidence that there's deterioration in the patient's condition by doing surgery for scoliosis. In fact, all scores that are documented so far look pretty good, but this is class 4 evidence. Other things that we see are that there's no clear relationship between SRS total scores and curve correction or curve magnitude. And there is some suggestion that SRS functional domain scores correlate with residual unfused segments. So when I think of the question, should we do surgery, we want to look at the natural history of adolescent idiopathic scoliosis, and I'd say there's pretty good evidence that there's decreased health-related quality of life over time in self-image, pain, and function. But it's not a life-threatening condition. And are we ever going to have level 1 evidence that surgery is effective compared to doing nothing? Probably not. This would take probably 50-year follow-ups, untreated, not treating any severe curves, and getting health-related quality of life scores. So we're talking about getting this data in the year 2050, which is not going to be very helpful for a lot of people. So my answer to the question of should we do surgery for scoliosis on this patient is that we can let him go ahead and do nothing, watch him, like we see on the left. This is the likely outcome. Or we can go ahead and do surgery now when the curve is flexible, easy to correct, and complication rate is fairly low. But since the natural history of this disease is not disastrous, safety is paramount. One patient with paraplegia is a disaster. So less risk trumps better correction in almost all circumstances. You should use instrumentation that you're comfortable with. There is a lot of emphasis being placed currently on doing very extensive releases to get better correction. We got to remember that correction does not correlate with outcome very well, and the more aggressive releases always increase your risk. Ponte osteotomies, Smith-Peterson, PSO, vertebral resection. Every time you add one of these, you add risk. So in conclusion, I would say you should do what you're comfortable with. You don't have to try to get home run correction, and you're probably on good footing doing scoliosis for a patient, doing scoliosis surgery in a patient, an adolescent with a curve over 50 degrees. Thank you.
Next, I want to introduce Dr. Chris Standaert, who's going to speak to another common pediatric problem, and this is the question of spondylolysis.
Thank you, Ted, and thank you, Jens and Randy, for the opportunity to come talk. This is a topic I have a fair amount of interest in myself. So we're going to take an evidence-based look at spondylolysis, that being the charge here. So just to make sure we're all talking about the same thing, you all know these words, I assume, but spondylolysis is a defect in the pars interarticularis of the vertebral arch. Spondylolisthesis, related term, but not the same, refers to interdisplacement of one vertebral body on the one below it. And for the purpose of our discussion, we're talking about isthmic spondylolysis is what we're discussing. So evidence, how good is our evidence on this particular topic? We have some problems here. It's not very good. So gold standard for diagnosis is not universally agreed upon. You read the literature on MRI, CT, SPECT, X-ray. People don't always agree on how you diagnose this particular problem, which makes it difficult because we don't have a true criterion or gold standard. When we go to treatment studies, we have no control trials. In fact, we don't even have a case control series. Everything are pure case series. We have no control to anything, which makes this difficult. Some things we do know, we actually have fairly good data on epidemiology. I think when you start looking at the epidemiology and the basic science of this, you learn a lot about this particular problem. Number of studies, if you look at the frequency of spondylolysis in the general population, it's about 3 to 6%, or roughly 5% of the adult population has a pars defect, at least one, on X-ray. And actually one of these studies, the one by Roach, was 2,000 spine cadavers that were dissected. And that's about the rate they found as well. A study by Fredrickson of first graders, 500 first graders, a number of years ago, 4.5% of these were present by age 6 and all asymptomatic. So this is our background rate of pars defects. More common in males than females. The vast majority are at L5. There is clearly an association with spina bifida occulta in a number of studies. And there's clearly a hereditary predisposition for this particular problem. Clinically, when we see it, though, we're not seeing asymptomatic 5-year-olds. We're seeing adolescent athletes. That's who has this problem as a clinical issue. They're a different group. When you look at the rates of spondylolysis in them, you have about 8 to 15% as a whole, which is much higher than the general population. There's a much more common finding in them and a much more common clinical problem in this group, particularly sports involving rotation and extension of the spine. We also know from a number of studies that spondylolysis is a very common cause of low back pain in adolescent athletes. Not only do we see them a lot when we x-ray them, but when they come in with back pain, it is the most common structural lesion we find as a cause of their back pain. This is a study from McKeely and Wood from Boston a number of years ago. They took 100 kids who presented to their sports medicine clinic with back pain, compared them to 100 adults who presented to an adult sports medicine clinic with back pain. Spondylolysis in about half the kids, about 5% of the adults, which is about what the demographics would tell us it is. So how do we do this? How do we find this? We have a problem. You can't make the diagnosis without saying you have one. You have to see it to make the diagnosis. It's not a clinical diagnosis. Most pars defects are present by age 6, and people are asymptomatic. We have plain X-ray, bone scan, SPECT, CT, MR, and very few comparative studies. So what do we know? For bone scan SPECT, high sensitivity, limited specificity. You see these, again, high sensitivity, but bone scans are fuzzograms. You're not really sure what it is. Bone scan and SPECT have a particular advantage, and there are a number of studies that really show that a hot SPECT or hot bone scan correlates to a symptomatic lesion, which is a very useful piece of clinical information. CT, very specific, sensitivity unclear. There's a big debate about particularly what do you do with a hot bone scan and a negative or normal CT? Is that a false positive bone scan, or is that a false negative CT, or is that just a very early stress fracture? CT has some specific advantages for us in that we can stage the defect to predict healing. We'll talk about that. MRI, very common now. I see a lot of kids come in with an MRI. MRI is excellent for other pathology. There's no radiation exposure. Big problems in terms of sensitivity and specificity and what we know and don't know about this particular modality. So what do we know? We have 2 comparative studies on these 3 modalities, and that's it. This one from Campbell et al., 2005, 72 patients with low back pain, all adolescents. They all got a SPECT and a CT, and in those 72 patients, they found 40 pars defects. 25 were chronic. They then did MRI on all these kids, the 40 pars defects, and went looking to see what they found. They did very non-standard MRIs, though, which I'll show you. What they found is that of the 40 pars defects, 39 had some abnormality on MRI, but only 3/4 correctly graded by MRI. And the biggest problem was in getting the ones that had a positive bone scan and a negative CT, the incomplete defects. This is what the pictures look like. And I've seen these pictures from our institution, but this is not a normal MRI sequence. This is not what people get in the community. And this is how they found it. And even with this, not great sensitivity. So, second study by Massey, prospective cohort, 71 subjects, bone scan, MRI, CT, 50 pars defects found, 39 had a positive bone scan, but only 19 of those actually were found on CT. So MRI only found 40 of the 50. MRI revealed 18 of the 19 fractures seen on CT, but again, what it really missed were the ones you find on bone scan that you don't find on CT. They felt gold standard SPECT, bone scan, and CT, and MRI was statistically significantly less accurate. So treatment, problem again, no controlled trials. A number of case series, that's all we have. Variations in treatment, rest, bracing, particularly a study from Steiner and McKaylee really sort of set the standard for a number of years, I think, in terms of bracing, 23 hours a day for 6 months. Rehab. An interesting thing is that the vast majority of studies, whatever they do, most kids do really well. So I talked before about CT and staging of defects. And this is relevant. We'll talk about why this is important. So when you look at these, the people who've talked about this in literature stage them by early, progressive, and terminal. This is an early stage defect. It's a sclerotic pars. There may be a small hairline fracture or incomplete fracture, but it's not a complete fracture line. Progressive, here in the circle, there's a fracture line. It can be cystic, it can be separated a bit, not widely separated, and no sclerosis. Terminal is essentially a non-union of bone. Sclerotic, clearly defined margins of bone. It's a non-union. On MRI, people talk about the edema in the pedicle rather than seeing the fracture. The edema in the pedicle is what helps you. So there's a picture, an axial of an MRI, and there's edema in the pedicles. High signal on stir sequences. And if you look at the CT, there's a corresponding axial cut of the same patient. You can't see the edema, but you see the fractures much better. These are progressive stage defects. But you can't really see the fracture very well on the MRI. Why are these important? Fujii in 2004 published a study of 134 kids. They used the CT classification. Of their early stage defects, 62% healed. Of their terminal defects, none healed. Interestingly, those that were unilateral, close to vertebral body, small slip, they all healed with higher frequency. No data on clinical outcome, though. Sarayo study this year, a similar thing. They looked at 23 patients, 41 pars defects, everybody got CT and MRI. Of the people with an early stage CT, 87% healed. So early stage fractures, highly likely to heal. Progressive stage fractures with edema on MRI, highly likely to heal at 60%. All the other ones, unlikely. So terminal stage defects or progressive with no signal change on the MRI, very unlikely to heal. They felt this meant there's no need to rest or brace to attempt healing in these people who will not heal, the chronic defects. Interestingly, again, MRI only found 63% of the defects over there on CT. And they did not do SPECT. So we have one meta-analysis of all the studies that are out there. It's actually a very well done study, just came out this year. They did an extensive lit search, 50 years, 57 years. Studies on children and young adults, spondies up to 25% slip. Had to have a year of follow-up, had to have at least 10 subjects. Non-operative treatment. They found 77 articles they went through fully. They included 22 of them in their study. They attempted to contact 25 authors for additional data and actually got more data from 6 authors. They did a pretty exhaustive search for data. They found 16 studies that assessed function and 10 studies assessed healing. And they did a very extensive data analysis, and all the studies are out there. Interestingly, the studies are highly heterogeneous except for the data on bracing. So when they looked at clinical outcome, good, excellent clinical outcomes in about 84% of kids, all studies pooled together. Very high rate, kids do better. Interestingly, when you look at radiographic studies, only 28% of kids really show healing. So we have a discordance here between healing and return to play and doing well clinically. Again, acute lesions, 68% healed. Progressive lesions, 28% healed. Terminal lesions, none healed. And if you're looking at sort of side by side, unilateral, 71%, 18% bilateral. So what they found for bracing, which again was their better set of data, more similar, less heterogeneous. So with a brace, 89% clinical success. Without a brace, 86% clinical success. Needless to say, not statistically significant. When you read what they really said data imply that bracing is not responsible for the clinical improvement, and this gives us a strong impetus to reconsider bracing as a standard treatment. So what do we do? I think from a diagnostic perspective, we really have level 2 to 3 data. We have decent studies on comparative imaging to tell us what to do. Limited plain films, we just do an AP and lateral. They don't help you with the diagnosis. They don't tell you if a pars fracture hurts. Seeing it on X-ray doesn't help you. Bone scan with SPECT and lumbar sacral spine we do first. If the bone scan is positive, or the SPECT is positive, we get a thin cut CT through the area of abnormality on the bone scan, on the SPECT, to see what the problem is. Is it a pars defect, and to stage it for healing. We don't re-image if there's, for routine follow-up if there's no slip. The only caveat I might have is if you had a young kid, like an 11 or 12-year-old, 13-year-old, bilateral pars defects, unslip, you still may want to X-ray them because they may go on to slip. You can consider repeat CT if you really need to get somebody back faster, but can be of limited utility. Treatment's tougher. The data isn't as good. And most of the studies, again, level 4 case series. I think the data is a bit better than when you look at when you really try to refine it because you can put in all the basic science data to give you some rationale to do what you're doing. So I think it's what we do has better data than that. So rest. So we rest them. Nothing beyond routine daily activity. There's no sports, there's no running, there's nothing. No picking up a basketball, nothing. We rest them. Duration dependent upon symptom resolution, how long it takes them to get better to a degree. Most kids will get better fairly rapidly. And the stage of the pars defect and the potential for healing. If somebody has a chance of healing this bone, even though it doesn't really associate with long-term outcome, it's a broken bone, we'd like it to heal. We tell them to rest for 3 months. And that's really based on sequential imaging studies. The earliest you ever see these things heal, when you image kids every single month, CT every month after they fracture, the earliest you ever see healing is 3 months. Nobody's ever documented healing at 2 months on a pars defect. And terminal, just until they don't hurt anymore. This is not going to heal. You don't have to sit them for 3 months. It's not going to heal. That's not one of your goals. Bracing, I use bracing very sparingly. I will only use it if people aren't getting better. And frankly, if you look at the data on bracing, bracing is an anchor. It weighs people down. It stops them from doing things. Bracing does not immobilize the lower lumbar spine. So it's not a useful tool for immobilization. They're adolescents. So if they are not getting better, they're not doing what you think, most of these get better. Reassess what is going on all the way through. Because they're kids and they have different sort of psychological basis. There are other things to be going on with them. If they're not doing what you think, reassess them along the way. I'm a rehab guy. We rehab them. So aerobic conditioning, spinal stabilization, range of motion, We work in the entire kinetic chain in terms of sports. If they want to play tennis, they want to play soccer. That's how they got in trouble in the first place. You have to get them back to what they're doing. Ideally, you get them back doing it better than they did it before they got hurt, because they probably got hurt for a reason. And if you can help them with that problem, with that reason, you may make them a better athlete. Just head one of the surgery thing. We have surgery. When do you operate on these kids? Personally, it's incredibly uncommon in my own experience, incredibly uncommon in the literature that you operate for pain from an isolated spondylolysis, pars fracture. Progressive or high-grade slip, certainly, instability, neurologic compromise. Then the intractable pain question, when do you operate? We don't have a lot of data. There are a number of procedures that have been done. There's a review done, just published this year by Radcliffe, which is interesting to read. Again, a whole bunch of case series, no good data on one procedure versus the other. And when you're going to go to operate, if you do, I personally always pose the question, why are you doing this? If the only reason is you have a gymnast who can't get back to level 10 gymnastics because their back hurts when they try, do you really think a fusion is going to help them do that? Be it a simple pars fusion, fuse the fracture, a screw, whatever you want to put in, wire it, or a whole segmental fusion. But is it going to do what you think it's going to do? I'm glad you all were listening. Thank you. Appreciate it.